Welcome to this comprehensive lecture on bacterial meningitis. Bacterial meningitis continues to occur amid vaccination efforts and causes significant morbidity and mortality, particularly in low-income countries. Prompt recognition and treatment are critical, as empiric therapy with antibiotics and dexamethasone must be initiated before diagnostic certainty is established. In this presentation, we will review the clinical manifestations of bacterial meningitis, emphasizing neurologic and systemic signs and symptoms that guide diagnosis and management. We will discuss diagnostic testing for individual organisms and broader testing with next-generation metagenomic sequencing. Key mimickers of bacterial meningitis will be extensively examined, along with the pathogenesis of the disease and prevention with vaccination and chemoprophylaxis when available. Bacterial meningitis is a serious infection of the meninges that continues to occur despite vaccination efforts. It causes significant morbidity and mortality, with higher prevalence in low-income countries where access to vaccines and antibiotics may be limited. The key to improving outcomes is prompt recognition of the disease and rapid initiation of empiric antimicrobial therapy, because the mortality and morbidity associated with delayed treatment outweigh the risks of initiating therapy in patients who may not have bacterial meningitis. Empiric therapy with antibiotics and dexamethasone is initiated before diagnostic certainty is established. A comprehensive approach to bacterial meningitis incorporates thorough history taking, neurologic examination, knowledge of pathogens endemic to the area, formulation of a differential diagnosis supported by imaging studies, and CSF analysis when feasible. Several key points are essential to understand about bacterial meningitis. First, Streptococcus pneumoniae is the most common causative agent of community-acquired bacterial meningitis worldwide, accounting for 50 to 70% of cases outside the neonatal period. Second, when bacterial meningitis is suspected, empiric antimicrobial therapy and dexamethasone should be initiated before performing lumbar puncture and obtaining cerebrospinal fluid for analysis. This is because the mortality and morbidity associated with delayed treatment outweigh the risks of treating patients who may not have bacterial meningitis. Third, despite significant decreases in morbidity and mortality with antimicrobial therapy, sequelae such as hearing loss, ischemic stroke, epilepsy, focal neurologic deficits, and cognitive impairment are common. Fourth, vaccinations are available for the two most common causative organisms, Streptococcus pneumoniae and Neisseria meningitidis. Finally, early diagnosis and treatment are critical for reducing mortality and morbidity associated with bacterial meningitis. Acute bacterial meningitis is classically associated with a triad of clinical signs and symptoms, which include fever, stiff neck, meningismus, and headache. However, the likelihood of all three being present is only 50%. An altered level of consciousness, either lethargy or stupor, should be added to the classic symptoms. At least two of the following four symptoms and signs, fever, meningismus, headache, and an altered level of consciousness, will be present in 95% of bacterial meningitis patients. Of these, fever is the most sensitive measure, and a temperature greater than 37.7 degrees Celsius, 100 degrees Fahrenheit, occurs in nearly everyone within 24 hours of symptom onset. Other common complaints include nausea and vomiting, which are often due to increased intracranial pressure. The most common physical examination findings of elevated intracranial pressure are papilledema and an altered level of consciousness, which often advance to obtundation or coma. On examination, meningismus is the pathognomonic sign of meningeal irritation and is defined as passive resistance to neck flexion. Kernig and Brudzinski signs are also classic signs of meningeal involvement. The Kernig sign is elicited when the patient is supine, the thigh is flexed at a right angle to the trunk, and the leg is extended at the knee. The sign is positive when resistance to leg extension occurs due to meningeal irritation. Brudzinski sign is positive when a patient in the supine position has spontaneous flexion of the hips and knees following passive neck flexion. Although highly specific, they both lack sensitivity, so their absence does not exclude the diagnosis. In a prospective study of 297 adults with suspected meningitis, these two signs had a sensitivity of only 5%, meaning that most patients with bacterial meningitis may not have these classic signs. Streptococcus pneumonia is the meningeal pathogen in 50% to 70% of individuals with community-acquired bacterial meningitis, and as such is the most common etiological organism outside the neonatal period. The most vulnerable populations are young children and adults older than 65 years of age, when immunity is most likely to be reduced. Major risk factors for developing pneumococcal meningitis include sinusitis, otitis media, and pneumonia. Patients often present with cough and dyspnea as common systemic complaints, and chest radiography will demonstrate consolidation in those with lobar pneumonia. Immunosuppression due to HIV, cancer, long-term use of immunosuppressive agents, such as in transplant recipients, and individuals with deficiencies of complement or immunoglobulin G are high-risk populations for developing pneumococcal meningitis. It should be noted that the classic signs of bacterial meningitis, such as meningismus, may not be present in immunocompromised patients, older adults, or children. Recurrent bacterial meningitis occurs in 6% of episodes and is most commonly caused by Streptococcus pneumonia, seen more commonly in patients with otitis, sinusitis, and cerebrospinal fluid leakage. CSF leakage represents an anatomic defect that allows recurrent bacterial seeding of the meninges. Patients with recurrent meningitis require thorough investigation for underlying predisposing factors, including immunologic deficiencies, anatomic defects, or CSF leaks. Identification of the source of CSF leakage may allow for surgical repair to prevent future episodes. The second most common organism associated with bacterial meningitis is Neisseria meningitidis. The classic triad of fever, meningismus, and headache is present in only 1/3 of individuals with meningococcal meningitis, compared to nearly 60% in pneumococcal meningitis. Distinguishing systemic features of meningococcal infections, including septic arthritis and meningococcemia, may be present, but are certainly not universally present. Septic arthritis is seen in 7% of adults with bacterial meningitis, and the most common cause was meningococcus. It is important to diagnose concomitant septic arthritis, as it requires surgical drainage and a longer course of antibiotic therapy. Disseminated intravascular coagulation may occur with the breakdown of blood vessel walls and the development of a classic petechial rash. In addition to a petechial rash, a maculopapular or purpuric rash may also develop in meningococcal meningitis. This distinguishes meningococcal meningitis from Streptococcus pneumonia or Haemophilus influenzae meningitis, where rashes are rarely observed. The overall specificity of a rash when present for meningococcal meningitis is 80% to 90%, with false positives likely attributed to individuals with other infectious etiologies, such as enteroviral meningitis or spotted fever rickettsiosis. The presence of a petechial or purpuric rash in a patient with meningitis should raise strong suspicion for meningococcal disease and prompt immediate empiric therapy. Listeria monocytogenes is a gram-positive bacillus that causes meningoencephalitis in a bimodal distribution, affecting infants and individuals above the age of 50 years, with particular impact on the immunocompromised population. In the Mona Lisa study, neurolisteriosis occurred more commonly in the elderly with a mean age of 67 years and in immunosuppressed individuals representing 83% of cases. In neonates, Listeria comprises 1/3 of all patients with meningitis due to Listeria monocytogenes. Infection typically occurs transplacentally from maternal bacteremia, although acquisition during vaginal delivery can also occur. neonates present with sepsis on the first or second day of life, along with fever and irritability. After the neonatal period, listeriosis is rarely observed in children. Outbreaks of Listeria monocytogenes infection in adults are associated with consuming unpasteurized dairy products, soft cheeses, deli meat, and seafood. Classically, listeriosis will produce a prodromal diarrheal illness before the development of meningitis. Meningitis due to Listeria monocytogenes may have fewer classic signs or a subacute presentation than meningitis due to other pathogens. For example, patients may present with confusion earlier in the course but may have a much milder or even absent stiff neck. Additionally, movement disorders such as myoclonus, tremor, or ataxia are present in 15% to 20% of patients and can be a distinguishing diagnostic clue. Another differentiating feature is brainstem encephalitis, rhombencephalitis, with involvement of the pons and medulla, which occurs in 17% of non-pregnant patients with Listeria monocytogenes meningitis. Lower cranial neuropathies, particularly facial paresis, cerebellar signs, and decreased level of consciousness due to involvement of the reticular activating system are common with rhombencephalitis. In a large multicenter French study, the presence of bacteremia and the use of adjunctive steroids were associated with higher mortality in Listeria meningitis. However, a follow-up observational study from the Netherlands showed different findings. In this study, bacteremia and age were identified as risk factors for adverse outcomes, but steroids were associated with decreased mortality. These conflicting findings highlight the complexity of managing Listeria meningitis and the need for individualized treatment decisions based on patient factors and clinical presentation. Haemophilus influenzae is a gram-negative encapsulated organism that is spread via respiratory droplets. Symptoms initially begin with an upper or lower respiratory infection that spreads by blood-borne dissemination to the meninges. Meningitis due to Haemophilus influenzae type B is no longer a common cause of meningitis in children due to successful vaccinations, but is a causative organism of bacterial meningitis in older adults. Understanding the epidemiology and presentation of different bacterial pathogens is essential for appropriate empiric therapy and management. The diagnostic approach to bacterial meningitis begins with lumbar puncture to obtain cerebrospinal fluid for analysis. CSF analysis includes cell count and differential, glucose, protein, gram stain, culture, and molecular testing. Gram stain can rapidly identify bacteria and guide initial antibiotic therapy, though sensitivity is limited. Culture remains the gold standard for bacterial identification and allows for antimicrobial susceptibility testing. Molecular testing with polymerase chain reaction can provide rapid identification of common pathogens. Blood cultures should be obtained in patients with suspected bacterial meningitis, as they may be positive in 50-80% of cases. Imaging studies, including CT and MRI, can help guide the diagnostic approach and identify complications. The cerebrospinal fluid profile can help differentiate between bacterial, viral, and fungal infections. Bacterial meningitis typically presents with CSF white blood cell count greater than 1,000 cells per microliter, with predominance of neutrophils, protein greater than 100 milligauss DL, and glucose less than 40 millimicrons DL, or CSF to serum glucose ratio less than 0.4. Viral meningitis typically presents with CSF white blood cell count between 10 and 1,000 cells per microliter, with predominance of lymphocytes, protein between 20 and 100 mg DL, and normal glucose. Fungal meningitis typically presents with CSF white blood cell count between 20 and 500 cells per microliter, with predominance of lymphocytes, protein greater than 100 mg DL, and low glucose. Tuberculous meningitis presents with CSF white blood cell count between 100 and 500 cells per microliter, with predominance of lymphocytes, very high protein greater than 200 mg DL, and low glucose. Gram stain of cerebrospinal fluid can rapidly identify bacteria and guide initial antibiotic therapy. However, sensitivity is limited, ranging from 50% to 90% depending on the organism and bacterial load. Culture remains the gold standard for bacterial identification and allows for antimicrobial susceptibility testing. However, culture results may take 24 to 48 hours or longer. Contamination of cerebrospinal fluid samples can occur and must be distinguished from true infection. Repeat, lumbar puncture may be necessary if initial cerebrospinal fluid is contaminated. Antimicrobial susceptibility testing guides definitive therapy once culture results are available. Polymerase chain reaction-based molecular diagnostics have revolutionized the diagnosis of bacterial meningitis. Multiplex PCR panels can simultaneously detect multiple common bacterial pathogens from a single cerebrospinal fluid sample. Examples include the film-array meningitis encephalitis panel, which can identify common bacterial pathogens, viruses, and fungi. PCR has several advantages over traditional culture methods, including rapid turnaround time, high sensitivity and specificity, and ability to detect non-viable organisms. However, PCR cannot determine antimicrobial susceptibility and may detect colonizing organisms or asymptomatic shedding. Positive PCR results must be interpreted in the clinical context. Negative PCR does not exclude bacterial meningitis, particularly for organisms not included in the panel or for rare pathogens. Neuroimaging plays an important role in the diagnosis and management of bacterial meningitis. Magnetic resonance imaging is preferred over computed tomography for evaluating bacterial meningitis due to superior soft tissue resolution and ability to detect subtle abnormalities. Imaging findings can help localize infection and suggest specific pathogens. Bacterial meningitis may show enhancement of the meninges and possible complications such as hydrocephalus or subdural effusion. Complications including ventriculitis and subdural empyema can be detected on imaging. Imaging guides clinical management and helps predict prognosis. Prompt initiation of antimicrobial therapy is critical for improving outcomes in bacterial meningitis. Empiric therapy should be initiated based on clinical suspicion before culture results are available. The choice of empiric therapy depends on patient age, risk factors, and local epidemiology. Common empiric regimens include ceftriaxone or cefotaxime plus vancomycin for bacterial meningitis. Ampicillin should be added for patients at risk for Listeria monocytogenes infection, including neonates, elderly patients, and immunocompromised individuals. Definitive therapy is guided by culture results and antimicrobial susceptibility testing. Adequate cerebrospinal fluid penetration of antimicrobial agents is critical for success. Some agents penetrate the inflamed meninges better than others. Dexamethasone is an adjunctive corticosteroid that reduces inflammation and improves outcomes in bacterial meningitis. It should be administered with or before the first antibiotic dose. Dexamethasone reduces hearing loss and other neurologic sequelae, particularly in pneumococcal meningitis. The use of adjunctive dexamethasone has been shown to reduce mortality and morbidity in multiple clinical trials. Dosing and duration are based on clinical guidelines and patient factors. Bacterial meningitis can cause several acute and chronic complications that increase morbidity and mortality. Acute complications include hydrocephalus due to obstruction of cerebrospinal fluid flow or impaired cerebrospinal fluid absorption, seizures which occur in 20 to 30% of patients, and increased intracranial pressure from cerebral edema. Cerebral venous thrombosis can occur and cause stroke. Subdural empyema, a collection of pus between the dura and arachnoid, requires urgent drainage. Chronic sequelae include hearing loss, which is the most common sequela occurring in 5 to 30% of survivors, cognitive impairment and memory problems, residual focal neurologic deficits, and epilepsy, which develops in 10-20% of survivors. Recognition and management of these complications is critical for improving outcomes. Hearing loss is the most common sequela of bacterial meningitis, occurring in 5% to 30% of survivors. Sensorineural hearing loss is the most common type, resulting from damage to the inner ear or auditory nerve. Hearing loss may be permanent or progressive, developing weeks to months after infection. Audiologic evaluation is recommended for all survivors of bacterial meningitis to detect hearing loss early. Hearing aids or cochlear implants may be beneficial for patients with significant hearing loss. Early detection and intervention can improve quality of life and developmental outcomes in children. Prevention of bacterial meningitis is important for reducing disease burden. Vaccines are available for the two most common bacterial pathogens, Streptococcus pneumoniae and Neisseria meningitidis. Vaccination recommendations vary by age and risk factors. Chemoprophylaxis may be indicated for close contacts of patients with meningococcal meningitis to prevent secondary transmission. Antiretroviral therapy and immune reconstitution reduce the risk of opportunistic infections in HIV-infected patients. Public health measures such as respiratory isolation of patients with meningococcal disease help prevent transmission. Education about symptoms and prompt medical evaluation can facilitate early diagnosis and treatment. A systematic approach to diagnosing bacterial meningitis improves diagnostic accuracy and patient outcomes. The first step is clinical suspicion based on history and physical examination. Neuroimaging should be performed to exclude contraindications to lumbar puncture such as increased intracranial pressure or mass effect. Lumbar puncture should be performed when there are no contraindications to obtain cerebrospinal fluid for analysis. Cerebrospinal fluid analysis, including cell count, glucose, protein, gram stain, and culture, should be performed. Molecular testing with multiplex PCR should be performed for rapid pathogen identification. Blood cultures should be obtained in patients with suspected bacterial meningitis. Empiric antimicrobial therapy should be initiated promptly based on clinical suspicion. Definitive therapy is guided by culture results and antimicrobial susceptibility testing. A 45-year-old previously healthy man presents with fever, severe headache, and neck stiffness for 12 hours. On examination, he has fever of 39.5 degrees, neck stiffness, positive Kernig and Brudzinski signs, and altered mental status. Computed tomography of the head is normal. Lumbar puncture shows cerebrospinal fluid with white blood cell count of 2,500 cells per microliter with 90% neutrophils, protein of 250 mg DL, and glucose of 30 mg DL. Gram stain shows gram-positive diplococci. Blood cultures are positive for Streptococcus pneumoniae. Empiric therapy with ceftriaxone and vancomycin was initiated immediately. Culture and susceptibility testing guide definitive therapy. The patient recovers with appropriate treatment but develops hearing loss as a long-term sequela. A 28-year-old previously healthy woman presents with fever, headache, and petechial rash for 18 hours. On examination, she has fever of 39.2 degrees, minimal neck stiffness, altered consciousness, and a petechial rash on her trunk and extremities. The presence of a petechial rash in a patient with meningitis is highly suggestive of meningococcal disease. Lumbar puncture shows cerebrospinal fluid with white blood cell count of 1,200 cells per microliter with 80% neutrophils, protein of 180 mg DL, and glucose of 35 million DL. Gram stain shows gram-negative diplococci. Blood cultures are positive for Neisseria meningitidis. Empiric therapy with ceftriaxone was initiated immediately. The patient responds rapidly to therapy and recovers without significant sequelae. A 72-year-old man with history of diabetes presents with fever, confusion, and tremor for 2 days. On examination, he has fever of 38.8 degrees, minimal neck stiffness, confusion, and myoclonus. The presence of myoclonus and minimal meningeal signs in an elderly patient should raise suspicion for Listeria meningitis. Lumbar puncture shows cerebrospinal fluid with white blood cell count of 800 cells per microliter with 60% lymphocytes, protein of 150 mg/dL, and glucose of 40 mg/dL. Gram stain shows gram-positive rods. Blood cultures are positive for Listeria monocytogenes. Empiric therapy with ampicillin and gentamicin was initiated immediately. The patient recovers with appropriate treatment. In summary, bacterial meningitis is a serious infection that requires prompt recognition and empiric therapy to reduce mortality and morbidity. Streptococcus pneumoniae is the most common causative organism worldwide, but other pathogens, including Neisseria meningitidis, Listeria monocytogenes, and Haemophilus influenzae, must be considered. Clinical presentation varies depending on the causative organism and patient factors such as age and immune status. A systematic diagnostic approach incorporating history, physical examination, neuroimaging, and cerebrospinal fluid analysis improves diagnostic accuracy. Early initiation of empiric antimicrobial therapy and dexamethasone before diagnostic certainty is established is critical for reducing mortality and morbidity. Long-term sequelae, including hearing loss, cognitive impairment, and epilepsy, are common and require ongoing monitoring and rehabilitation.